Hello and welcome to Bite-Sized MRCP, a manageable way to digest the things that you need to know for your MRCP exam. We are two junior doctors based in the UK who have passed all three parts of the MRCP within the last 5 years and want to help you do the same. We're not associated with any MRCP examination organizations, and the materials covered are by no means an exhaustive list of what can come up in your exam, and indeed are not intended to be used as medical advice. Please refer to your College of Entry or your friendly supervisor for further questions regarding the exam and syllabus. If you like the sound of what you hear today and would like to join us for more bite-sized revision, give us a thumbs up and press the subscribe button. Now, without further ado, let's get into today's topic, which is on Basal Cell Carcinoma, or BCC, under the section of Dermatology. What is BCC? It's a malignant neoplasm of epithelial cells. The cancer grows slowly. It is locally invasive and it rarely metastasizes. As is for epidemiology, it's the most common human neoplasm. It has a high incidence in countries with high UV light intensity and Caucasian skin, such as Australia and New Zealand. With regards to its risk factor, as we discussed, UV light radiation and ionizing radiation are two of the commonest reasons for developing BCC. Other risk factors include arsenic, topical nitrogen mustard, and genetic syndrome, which are really rare, such as Gorlin syndrome. BCC is normally divided into 4 different types. The classic one is the nodular pattern, which is your classic pearlescent papillar nodules with overlying telangiectasia of the skin. They are mostly affecting the head and neck. Another type is a superficial BCC, which is the erythematous scaly plaque or patch with a pearlescent border, and it commonly affects the trunk and the limbs. The third type of BCC is the morphic or the sclerosing type, which has a white-yellow plaque with scar-like appearance and most commonly affects the head and neck. And the final type of BCC is the pigmented type, which causes speckled or uniformly distributed pigments and may have an overlying pearly shiny skin. So this is just to show you a classical picture of a BCC. These are really common on the face and also on the trunk. And here you can see a round pearly-like lesion in the nasolabial fold. In order to investigate the potential cause of a BCC, it's really important to take a thorough history, including covering all the risk factors that we have already discussed. This will be followed by a clinical examination, and there should be a complete examination of all the skin, including lymph nodes. This is normally done on the guidance of a dermatologist with the use of a dermatoscope. And finally, if there is a concern about the potential BCC, it's important to have the lesions biopsied to confirm the diagnosis. The treatment goal in BCC is complete eradication. And the treatment name that you need to remember as far as the MRCP is concerned is Mohs microscopic surgery. So this is a surgical technique that is used to surgically excise with histological intraoperative control of tumor margins. In some special cases, it could be the other methods that could be used are cryotherapy and curettage. And in rarer cases, especially if there's a concern about potential metastases, radiotherapy will also be helpful. As for its prognosis, overall the prognosis is pretty good. It's very unlikely for the BCC to recur with appropriate treatment and full surgical excision. However, about 20% of patients will develop another unrelated BCC within 5 years. In terms of disease associations, it's really important that whether it's a case of PACES or a question on the written exam, you be thinking about this potential association with the BCC. These are really common in patients who have been on long-term immunosuppressants. For instance, patients who've had any type of transplant surgery, patients who have immunodeficiencies such as HIV, And finally, in rarer genetic conditions such as Gorlin syndrome. Okay, let's do some questions. An 80-year-old Caucasian lady presents with a 6-month history of a 2-centimeter pearlescent nodule over her nasolabial fold. Given the likely diagnosis, what is the most appropriate treatment option? A. Camouflage. B. Curettage. C. Cryotherapy. D. Mohs surgery. E. Topical steroid. Hopefully, this is ringing alarm bell in all of you that this is a classic history of somebody presenting with a BCC. You have an 80-year-old lady who has white skin and has got a relatively slowly progressing, is a 6-month history of a small 2-centimeter. And the key really is the pearlescent nodule on her nasolabial fold and the location of it. So hopefully you have got the BCC, and as you remember, the gold standard treatment for excising the BCC is the Mohs surgery. Option A is completely irrelevant. Doing camouflage or makeup is not going to take the problem away. Curettage and cryotherapy are potential options. However, they're not the gold standard and the first line treatment that you should be offering the patient. And topical steroid won't make any difference in the treatment of the cancer. So the correct option is option D. Thanks for listening to this episode of Bite Size MRCP. If you like what you heard today, give us a thumbs up and hit the like and subscribe button to make sure that you don't miss out on our next episode. Let us know in the comments which topics you would like to hear in the future. See you in the next episode.